Anticoagulation Principles, Warfarin, Part 2b, Drug Interactions. The last time we talked about warfarin's mechanism of action and pharmacokinetics. Today, in Part 2b, we'll talk about warfarin's many drug-drug interactions. There are four key pharmacokinetic mechanisms for drug interactions with warfarin. They include enzyme inhibition, enzyme induction, decreased plasma protein binding, and reduced absorption. Stereoselective drug interactions may occur with warfarin. These interactions affect the oxidative metabolism of either the S isomer or the R isomer of warfarin. The inhibition of S-warfarin metabolism is more important clinically because this isomer is 5 times more potent than the R isomer as a vitamin K antagonist. The long list of warfarin drug interactions is beyond the scope of this lecture to present comprehensively. Therefore, only the most clinically significant interactions will be presented. Many are single case reports and are not well documented. Pharmacists are encouraged to investigate the potential drug interactions when monitoring warfarin patients on multiple drugs not listed here. Let's first talk about the drugs that potentiate warfarin's effect. One of the more important drug-drug interactions with warfarin is a combination with amiodarone. This is a very significant interaction. You might need to reduce the warfarin dose by 30 to 50%. Amiodarone is a CYP2C9 inhibitor. It's a potent inhibitor of the metabolic clearance of both the S isomer and the R isomer. It happens more rapidly with amiodarone loading doses. And amiodarone has a long half-life. The effect may be delayed and take longer to stabilize. Also, it can take 6 months after stopping amiodarone before the warfarin dose needs to be increased. Here are some other drugs that potentiate warfarin's effect. Allopurinol. This occurs within 2 days, and it can be a dramatic increase in the INR. It is not enzyme related. Oxandrolone. Oxandrolone significantly potentiates the anticoagulant effect of warfarin, the mechanisms by which are unknown. Fluorouracil or capecitabine. This has a black box warning about increased INR. These drugs inhibit CYP2C9. Antibiotics play a major role in interacting with warfarin. We will discuss this on the next 3 slides. All antibiotics have the potential to potentiate warfarin's effect, some more than others. This includes broad-spectrum antibiotics such as the sulfonamides, macrolides, quinolones, and tetracyclines. Here's what happens. Bacterial flora in the gut produce vitamin K. Antibiotics eliminate these bacteria, reducing vitamin K production, thus augmenting the anticoagulant effect of warfarin. Also, people don't eat well when they are sick, so their diets are deficient in vitamin K. Let's talk specifically about the azole antibiotics. These antifungals, fluconazole, ketoconazole, and voriconazole, cause a rapid, dramatic increase in the INR. Fluconazole and voriconazole inhibits CYP2C9. Posaconazole, on the other hand, may be an exception since it is not metabolized by 2C9. Other azole antibiotics include metronidazole and trimethoprim sulfamethoxazole. These antibiotics inhibits the clearance of the S-warfarin isomer, a stereoselective interaction. Other important antibiotic drug interactions with warfarin include the quinolones. The exact mechanism of this interaction is unknown, but it may be due to disruption of the gut flora, displacement of warfarin from albumin, and/or inhibition of the CYP1A2 metabolism. of the fluoroquinolones, ciprofloxacin and ofloxacin appeared to be the most likely to interact with warfarin. Also, the group of cephalosporins, second and third generation, caused decreased clotting factor production by inhibiting vitamin K recycling. It's important to remember that certain psychotropic agents can potentiate warfarin's effect. Fluvoxamine and fluoxetine inhibits warfarin metabolism mediated by the CYP2C9 enzyme system. Quetiapine is a CYP3A4 substrate. You will see an increased INR with this combination. And valproic acid causes protein binding displacement. You'll see increased warfarin levels and an increased INR. Here are some others. Leflunomide, or Arava, is not widely reported, but it may cause an INR increase to the point of causing bleeding. Cloffibrate and fenofibrate has an unknown mechanism. And thyroxine, as we talked about earlier, increases the metabolism of coagulation factors. This occurs when the patient starts, stops, or adjusts the dose of levothyroxine. Other drugs to consider that potentiate warfarin's effect are salicylates. This occurs with doses that are very high, possibly by interference with the P450 enzymes. Celecoxib is suspected of potentiating the effect of warfarin. Acetaminophen in large doses over a long period. This requires a Tylenol dose of 1.3 grams per day for 7 days. It's possible that there's an inhibition of the V-core enzyme by the toxic APAP metabolite. It prolongs the INR to greater than 6. It's important to remember that acetaminophen is still the analgesic and antipyretic choice for patients on warfarin. Now let's shift gears and talk about those drugs that reduce warfarin's effect. Here is a list of 5 common hepatic enzyme inducers that stimulate warfarin metabolism and reduces its effect. The list is small but very important. The first drug class are barbiturates. The second is the anti-seizure medication carbamazepine. The third is phenytoin. The fourth, rifampin. And the fifth, azathioprine. All 5 of these drugs are hepatic enzyme inducers, which metabolize warfarin faster and lowers warfarin's effect. Carbamazepine is a potent inducer of CYP1A2 and 3A4. Here are some drugs that reduce warfarin's effect via GI tract binding and reducing absorption of warfarin. Cholestyramine and cholestypol impairs warfarin absorption via the intestinal binding. It reduces the effect of warfarin. Cholestyramine and cholestypol should be taken at least 6 hours apart from warfarin. Another drug that works similarly is sucralfate. It's the same as the other 2 drugs, except wait 2 hours before or after the warfarin dose. What about the effect of alcohol on warfarin? Long-term consumption of alcohol induces the CYP2C9 enzyme system, which increases the hepatic metabolism of warfarin. So we may need to double or even triple the warfarin dose in these cases. It takes about 5 to 7 days for maximum effect of this interaction. However, short-term consumption of alcohol inhibits warfarin metabolism, causing an acute elevation of INR. Here are some other effects related to warfarin. Aspirin, NSAIDs, and high doses of penicillin inhibits platelet function. Aspirin and NSAIDs can also produce gastric erosions that increase the risk of upper GI bleed and thereby increase the risk of warfarin-associated bleeding. Heparin. Heparin in therapeutic doses produces only a slight prolongation of the INR. During initial therapy with warfarin, the interference with heparin anticoagulation is of minimal clinical significance. However, warfarin may increase the activated partial thromboplastin time, APTT, even in the absence of heparin. What about the effect of herbal remedies on warfarin? St. John's wort, ginseng, and green tea have a possible small reduction in warfarin's effect. Glucosamine, coenzyme Q, and vitamin E have no significant effects seen on the INR. The clinical implications are unclear, as single case reports are unvalidated and unreliable. Commonly used drugs like cimetidine, omeprazole, and erythromycin inhibit CYP3A4 and reduces the clearance of the less potent R-warfarin isomer. This potentiates the INR only modestly. Here's a summary list of drugs that can interact with warfarin, leading to an enhanced effect and elevated INR values. Here's a summary list of those drugs that can reduce warfarin's effect. And here is the combined list for your review. In Part 2b, we describe warfarin's significant drug interactions that increase and decrease its effect. In Part 3 of this 4-part series on warfarin anticoagulation, we will define INR and see how it is used to monitor warfarin. We'll outline how to select the initial warfarin dose and how to adjust the dose. We'll describe how to manage subtherapeutic and elevated INRs, and we'll define bridging therapy and when to use it. So stay tuned. Thanks for tuning in to watch this installment of the PharmEasy Tutor. I hope you learned something that you could use at school or in practice. If you'd like to continue to see more of these types of tutorials on YouTube, please make sure to click on the subscribe button below to change it from red to gray. Also, if you like this video, I would appreciate it if you can click on the thumbs up icon below to change the color to blue. If you have any comments or questions, please feel free to add them in the comments section below, or share this site with someone else. Stay tuned to the PharmEasy Tutor channel for more lectures in the upcoming weeks. So until next time, remember to take it easy.